Welcome back to the Collidescope series, where we discuss interesting renal pathology cases that have two diseases that collide or meet in one patient. I'm Dr. Charles, and I am joined today by our fellow in training, Dr. Alan Lim. Alan, how are you doing today?
I'm doing really well, thanks. How are you?
Pretty good. Happy to be here. So today I have a rare collision case that I'd like to share. Are you ready to get started?
Yes, let's do this.
So the patient is an 82-year-old woman with a history of diabetes, hypertension, and metastatic ovarian cancer on Keytruda, who presents with acute on chronic kidney disease, serum creatinine 4.47 milligrams per deciliter, and proteinuria 2 grams on urine protein to creatinine ratio.
What does the light microscopy show?
Staining with an H&E stain at low power, we could see 3 fragments of tissue. Here we could see 1 cortical fragment, and these 2 fragments are medulla. From low power, we could see moderate inflammation throughout the cortex and medulla that's somewhat patchy. Again, on a higher power image, we could see scattered cortical inflammation and acute tubular injury. Here on a higher power image on H&E, we could see that this inflammation is predominantly composed of lymphocytes and plasma cells. There are a few scattered EOs here and there as well.
That amount of inflammation is concerning for acute interstitial nephritis. Was there any tubulitis?
Good question. So, yes. So here on the PAS stain at a higher power, we could see several foci of tubulitis, lymphocytic tubulitis.
Was there any activity in the medulla?
Yeah, so staining with a low power image on H&E, we could see there's scattered inflammation within the medulla. We could see that there's actually a focal lesion within the medulla here. Zooming in on this focal lesion in the medulla, we could see that there's non-caseating granulomatous inflammation, and there's also scattered plasma cells too.
So granulomatous inflammation and scattered lymphocytic tubulitis is consistent with the granulomatous interstitial nephritis. Could this be related to the checkpoint inhibitor therapy?
Exactly. So the differential of granulomatous interstitial nephritis is broad and includes drug/hypersensitivity reaction most commonly, one example of which is checkpoint inhibitor therapy related AIN. Other etiologic considerations include infections, particularly mycobacterial and fungal, autoimmune disease, and sarcoidosis, which is a diagnosis of exclusion. In this case, the AFB and GMS stains were negative for mycobacteria and fungal organisms, respectively, and the granulomatous interstitial nephritis in this case was favored to be secondary to the patient's Keytruda use.
Interesting. I usually think of checkpoint inhibitor nephritis as a lymphoplasmacytic-rich acute interstitial nephritis rather than a granulomatous interstitial nephritis. How often is it that we see granulomatous pattern secondary to checkpoint inhibition?
Good question. There isn't a lot of data on this topic, but a small case series from 2016 reviewed 13 patients with checkpoint inhibitor acute kidney injury, 12 of which showed the typical acute tubular interstitial nephritis, with 3 having granulomatous features. So while it is not the most common pattern, it can occur in a subset of cases.
Okay. So going back to the biopsy, were there any glomerular findings?
So looking at a PAS stain on higher power, we could see the glomeruli showed mild mesangial expansion, which was likely related to the patient's underlying diabetes.
Did you perform a Congo red stain?
Yes, so the Congo red stain revealed several scattered positive congophilic deposits, predominantly involving arteries, arterioles, and rarely a glomerular arteriole here seen on the left.
So it looks like the congophilic deposits show apple green birefringence under polarized light, consistent with amyloid deposition. Was there any evidence or hints for this on light microscopy?
The only evidence for amyloid on light microscopy was that some of the arteries and arterioles had silver negative material within the vascular walls, as seen here. But this is a subtle finding and can be easily missed without a Congo red stain.
Were there amyloid deposits on immunofluorescence? And if there were, did they restrict for kappa or lambda?
Yes, so a Congo red stain was performed on the frozen block shown here. And similar to the light microscopy block, it stained a few scattered arterioles that did not restrict with kappa or lambda on immunofluorescence staining.
Okay, so now did you do an AA or a LEC2 stain to try to further characterize the amyloid?
Yes, so LEC2 amyloid IHC was performed, and this was negative. And AA amyloid stain seen here highlighted scattered arterioles within the biopsy, which matched the Congo red distribution of deposits consistent with an AA amyloidosis.
Wow, okay. So we have a collision of entities here. On the one hand, we have a granulomatous interstitial nephritis secondary to checkpoint inhibitor therapy, in other words, checkpoint inhibitor nephritis. And on the other hand, we have an AA amyloidosis. Could these two entities be related?
Yeah, so AA amyloidosis is typically associated with systemic chronic inflammation derived from proteolytic cleavage of serum AA protein, which is an acute phase reactant. This typically occurs in the setting of autoimmune disorders like rheumatoid arthritis, ankylosing spondylitis, inflammatory bowel disease, or chronic infections. However, a review from 2023 showed that AA amyloidosis is associated with several types of cancers and malignancies. Amongst solid tumors, it was most commonly associated with renal cell carcinoma. Other common tumors associated with AA amyloid included lung cancer and different skin cancers like basal cell carcinoma. Also within this review, AA amyloid was reported in a substantial number of cases treated with immune checkpoint inhibitors, with a hypothesis that the increased cytokine release from the activated effector T cells could be driving the pro-inflammatory environment. This review from 2023 hypothesized that AA amyloid could be directly produced by tumor cells or the inflammation that the tumor causes, or just the inflammatory response like anti-tumor macrophages could be responsible for the upregulation of serum amyloid A protein. So in our case, the patient had been on Keytruda for a few months, so it's possible that inflammation from the checkpoint inhibitor nephritis was driving the AA amyloid. It could also just be related to the pro-inflammatory environment of having an ovarian cancer and being on chemotherapy treatment.
Wow, this is a really interesting case. So to summarize, checkpoint inhibitor nephritis typically shows an acute tubulointerstitial nephritis, but a subset of cases can have a granulomatous component. AA amyloid is the second most common type of renal amyloidosis behind AL amyloid, and AA amyloid is classically associated with chronic infection, secondary to autoimmune and/or infectious etiologies. However, numerous case reports and case series are now linking AA amyloidosis to various solid organ cancers and even checkpoint inhibition therapy. Well, thanks everyone for joining us. Hope you all can join us again next time.